we have come together again to learn. For me, the learning aspect of this conference is very important, and I hope you can learn as much as I do every year. The mission of CLINAM Foundation is to contribute to the medicine of the future by advancing nanomedicine and related sciences to the benefit of patients and society. And this is the red line throughout this conference. Now, I'm a medical doctor, and that means let me start with the question of benefit to patients. The CLINAM conference has various kinds of content. And the key questions which I hope you will find answer for during the conference, and which I hope for myself to find answers, are the questions related to patients. What do patients and society need? Then with a focus on nanomedicine and targeted medicine, what novel technologies are ready for the medicine of the future? Can we translate them to an industrial stage? And can we translate them to clinical practice? Then we will raise governance questions. How can governments and funding agents empower this transition to a medicine of the future? Can regulatory agencies become a catalyst to accelerate this transition? And what are the need for startups and existing industries in the field? And then the question of implications. What are the implications of such innovation? Also the wider view. How about global health and sustainability? Now let's jump into a patient of mine. This is a man of 65 years who comes to my hospital with myocardial infarction. And what you see here is the right coronary artery, which is occluded. And this leads to acute myocardial infarction. The patient comes to my cath lab, and we start an intervention on this vessel. First, we put a small wire into the vessel, which you might see on the screen. And we aspirate some of the thrombotic material in this artery, and you see that there is some improvement on peripheral perfusion of this artery. As a next step, we put the balloon and the stent to the location of this occlusion, and we can confirm that this vessel is now nicely reopened, and we have re-established flow to the periphery, which strongly reduces the size of infarction and increases the life expectancy and the prognosis of this patient. Now, this is a very nice example because we have acted early and efficiently. A similar patient who is 10 years younger had the very same situation with occlusion of the right coronary artery, but this patient went into cardiogenic shock. Cardiogenic shock is probably the worst disease you can get because the risk of death within the first few days is 50%. This is worse than most other diseases you can attract. And here technology has advanced significantly. What you see here is how I introduce in the movie a catheter-based pump into the heart, which replaces the natural heart function of the pump and saves this patient's life. This is a German development, by the way, so Europe is innovative in this field. And the patient stabilizes somewhat, but what then occurs is that there is a problem with the right heart. You know, we have two ventricles, one on the left, which is now supported, and we have a right ventricle, which is not supported, and this patient deteriorates again. Now what we did is we introduced a second device. This is this pump on the right side. And this is worldwide the first patient who got two percutaneous assist devices for the heart. And he survived this disease. And here you see himself and his family a few months after the event. He has completely recovered. And we actually are very proud that he has recovered. But this is just the reminder that medical technology has advanced a lot. 40 years, 50 years ago, if you had a myocardial infarction, your risk of death was largely beyond 30% in the hospital, and now it has decreased to about 5% in the hospital due to these advances. What does this mean? This means that if you look at the risk of death in myocardial infarction, the risk of death is highest very early on, And we have improved in pre-hospital management, CP resuscitation measures, balloon stentings, shock measurement. But this opens a second problem now, which is the phase after the infarction. And what we know today is that atherosclerosis, which leads to infarction, does not stop with successful treatment of myocardial infarction. And that means these patients survive, but they come into a stage where they develop atherosclerosis progression and heart failure. Now let's again look at the first patient. The first patient came to a hospital. He had a PTCA, a catheterism, an EKG, a PTCA, which helped him, a letter to his physician that everything is good now, and an echocardiogram. So this looks very simple. But let's look at the following year. These are now the exams which we had to perform in the second year, which means we did a catheterism again, another balloon, another stenting, then another catheterism, another stenting, another catheterism. So this patient came back several times to us. Let's look at the following year. The list gets longer. You see many exams, many interventions. Up here, an ICD implantation. This is a specialized pacemaker which costs about 50,000. And what you see is we have saved the life of these patients in the beginning, and this has led to a real problem in the follow-up. Now, what are the main killers in our society? If you look at the causes of death on a global scale, we know that infectious, maternal, perinatal, nutritional deaths are very important in developing countries, and cardiovascular disease is the killer in Western countries. Also important is cancer, but to a significantly lower degree than cardiovascular, and we have other chronic illnesses. So if we want to reshape the medicine of the future, we need to have this distribution of diseases in mind. Now, what is infection management in the 20th century? Let's look at malaria, the main killer worldwide. We treat an acute episode, and we know that the patient will be infected again soon thereafter, requiring diagnosis and treatment again. No eradication of malaria today. 600,000 dead children per year, recurring treatment costs, and a huge economic loss. Let's look at HIV infection. Today we have achieved a stage where the life expectancy of HIV infectious patients has much increased. So we know that life expectancy with HIV is slowly moving towards a normal life expectancy. Why so? Because we have found this multi-drug, highly active antiretroviral treatment, which the patient has to take every day during his lifetime, and which costs about $35,000 per patient per year. Let's look at cancer. Cancer therapy in the 20th century, many side effects, few cures, high case costs. If we move to atherosclerosis, we have much advanced in acute disease management, operations, stenting, but this is followed by lifelong medication, which only can achieve a moderate risk reduction. Many patients will progress to heart failure, and most patients will come back to have another intervention. So we have expensive long-term medication, no cure. What will Europe's society mean? We have the keyword Horizon 2020. Let's look at this Horizon 2020 and the Horizon 2050 in terms of demographics. One thing we know for sure. Over the next 20 to 50 years, the payers will decrease and the proportion of consumers of healthcare will largely increase. That means even today, where we are in a crisis of healthcare financing, we know that tomorrow and in a few years, the situation will be much worse. What does mankind need? If you look at this global map of life expectancy, 2010, then we see that those who can afford it least need it most. So adding to this problem of healthcare success, healthcare financing. So to summarize, or to look at the main cost drivers now, we see that the annual disease costs in 2010 in billion US dollars only for cardiovascular diseases are $287 billion per year for atherosclerosis, compared to Horizon's 2020 research budget of 70 billion for 6 years. And this shows the huge disproportion of how our society spends its funds. We spend so much money to kind of do follow-up treatment, and we invest relatively little money on a societal view in improving this situation. So the successes of 20th century's medicine are its demise. And will it be? And the question is there a way out of this situation? And this is a slide I have shown last year. It's still relevant. If you want to contain cost and societal burden of disease, then we should stop reimburse ineffective activities. This is already increasingly done. We have the option of rendering medicine worse by limiting access, and that's what we see in some countries in Europe and abroad. But the best option would be to render medicine better, to make it more effective, less toxic, to increase cost effectiveness by personalization, and to have a big goal of medical research, the question of cure instead of palliation, and of eradication of major diseases. Now, in this conference, we see that a number of contributions to these goals is actually in the pipeline. For example, if you look at infection management of the future, we see that several presentations in this conference will show how to improve malaria management by inexpensive multi-parameter point-of-care diagnostics, which are the prerequisite for any eradication effort. We see targeted therapeutics nanoplatform. We see novel strategies for targeted transmission control paradigms, which can break the infection cycle in this disease. If you look at cure and eradication, you know that HIV vaccines were a recurring topic at this conference, and targeting cellular virus reservoirs is one of the scientific prerequisites to master this virus invasion in the body in the long term if we don't talk of suppression only. If you look at the cancer management of the future, then cancer cures may be enabled by contributions from this conference, namely nano-array diagnostics for molecular characterization and personalization of cancer medicine, by early detection of circulating cancer cells, by nanomaterial-based targeting, by functional nanomaterials, by antibody targeting, by cell-based therapies and targeting, by identification and targeted elimination of cancer stem cells, and by siRNA targeting by nanomaterials, which really is starting to flourish recently. If you look at atherosclerosis management of the future, we see that this idea, this concept of atherosclerosis eradication, which I define as no clinical cases occurring in a society, might be achievable in this century, maybe in 10, 20 years. And this needs molecular plaque imaging, shown in this conference, nanomaterial-based targeting, personalized risk prediction, nucleic acid targeting for profound metabolic reprogramming, functional nanomaterials. Now, if we cure the major killers, will humans become immortal? So this is the idea of the transhumanist philosophy. Now, if you look at epidemiologic and biologic data of aging research, we see an interesting development of these curves. We see that the survival curve, here observed in Swedish women, moves to the right upper border of the screen. But at the same time, if we look at the foot, at the lower range of these curves, we see that it seems that these curves narrow. Now, this development seems to indicate that humans will not live eternally. But there is something which stops viability somewhere at the age of 100. It seems that our biological batteries, reserves, decay at this age. There are some biologic insights into that process, including, for example, telomere research, stem cells. But this means for a society that what we can expect if we improve medicine is not a society which lives forever, but a society where the incidence of disease during the lifetime up to 90 years decreases. So we hope to have a healthier life, knowing that our life will end at 100 years, or maybe in a few individuals a little later. So we hope that we have a disease-free, independent life, free of chronic medication, free of repeat interventions for atherosclerosis, knowing that the human body will not last much more than the upper limit. If you look at the medicine of the future, there are limitations and threats. And in biology and medicine, we are not such a concise science like, for example, mathematics or physics. The mathematicians and the physicists have found out a long time ago, for example, with Godel, that there are limits to mathematics. So there is no mathematical theory which can be complete and free of contradiction at the same time. And physicists know the same. We have physical limits to what we can achieve. And the same is very probably true for biology. So we are not God, we will not live eternally, we will not be all wise. There are limits to this. A threat to the medicine of the future is the age pyramid and the cost I have shown. Another threat to the new medicine are the old paradigms. And the current drug development pipeline, for example, is still strongly adapted to the old paradigm of blockbuster medicine. Then we know all that in society there are always innovation drivers, but also innovation barriers. And another threat to the medicine of the future is the access to healthcare question, the north-south divide and the social divide. Now, how can we integrate nanomedicine and targeting for a medicine of the future? The first step is to apply nanotechnologies for diagnostics. And here we know that a broad range of technology is increasingly applied to these diagnostics, including fluidics, nanophotonics, nanoparticles, nanoelectronics, nanomechanics, nanotechnology-enabled deep sequencing. They have already found broad application because their regulatory hurdles are less important. We are about to widen the scope of therapeutics, including extending pharmaceuticals by biotechnological approaches, by nanomaterials, by more complex nanosystems. We go towards targeting of cells, targeting by cells, targeting new pathways, targeting tissues like the atherosclerotic plaque, targeting cancer cells, including cancer stem cells, by delivering not only drugs, but also by delivering nucleic acids like siRNA, and by delivering functional switchable materials. So the developing knowledge-based personalized medicine means we hope to analyze and understand disease-specific and patient-specific molecular features much more profoundly than we did in the past and we do now. We would like to derive rationally biomarkers for diagnosis, target receptors for delivery, target pathways for drug interference, target genes for RNA inhibition. Then we would like to design and assemble optimal therapeutic nanosystems tailored to an individual patient. And we would like to hit the target selectively and strongly. And finally, we would like to monitor disease course by, in a sustainable fashion by biomarkers which we have found before, and react to resistance development in due time. This means that we need to bring together the players, and this is the raison d'être of this conference. We need to bring together the specialists in technologies, namely molecular profiling, molecular imaging, therapeutic targeting, predictive modeling, and many more. We need to enhance the translation platforms, characterization, certifiability, regulation, technology transfer and financing of new ideas, dissemination and education, and finally we need to find a way for clinical implementation and economic optimization for the big diseases, also for smaller diseases, and we need to do that in parallel with economic optimization of these approaches. So the agenda of the medicine of the 21st century is knowledge-based medicine. We want to understand and know what we are doing. We would like to cure major diseases. We would like to eradicate specific diseases. We would like to personalize diagnosis and therapy. We would like to understand system aspects. And we want to move towards a cost-effective and high-quality medicine. So we would like to cure diseases by treating once and then forgetting this disease in an individual. We would like to eradicate, meaning no clinical cases occurring in a society. This would also eradicate my profession as an intensivist and cardiologist, as you know. Thank you for your interest. Are there questions?